ये तुझे अपना म्यूट रख।
Hello. I think we are just going to start today. We have a discussion. This is the hall D, which is on endoscopic ultrasound. We have two eminent speakers. First, I would like to call upon Dr. Prakash, who is a very well-known gastroenterologist from Lycia Hospital, and Dr. Matthew sir is there here, and Dr. Satya Prakash sir, and Dr. D. Srinivas, Manjunath, and Apurva, and Dr. Sukanya. I think first Dr. Prakash is going to highlight us EUS drainage of pancreatic fluid collection, when we should be doing and what. I think this is the thing which is going to highlight in next 20 minutes. Dr. Prakash,
yeah,
can you share the slides?
They are going to start from the other side. The recording will be played. That's what they told me. If not, I will share my slide.
I think, Prakash, if there is no information from them, you can start presenting for your this thing also. Anybody from admin? Are you sending? Are you playing the recorded version or visual?
I am not able to share my screen because the admin people have blocked it.
Okay, sir, please. I share, sir.
SCI, senior colleagues and dear friends. Let me thank Dr. Manoj Kumar Sahu and Dr. Avinash for giving me this opportunity. I'm also honored to be part of this panel discussion with Dr. Sandeep, who is a pioneer in management of pancreatic fluid collection. So I would talk about EUS drainage of pancreatic fluid collection, what and when. There are different type of pancreatic fluid collections which occur after an acute pancreatitis. This can be within the first 4 weeks or after the 4 weeks of the index incident. This can be an acute peripancreatic fluid collection which occurs after an interstitial pancreatitis, or an acute necrotic collection after a necrotizing pancreatitis. After a 4-week period, some of these fluid collection develop an encapsulation leading to pancreatic pseudocyst or walled off necrosis. But some of this fluid collection may also disappear. Of this, a pancreatic pseudocyst and walled off necrosis are the one which are usually managed endoscopically. While pancreatic pseudocyst, there is no solid content. The walled off necrosis has liquid as well as non-liquid content and might contain loculations. So when should one intervene endoscopically? Not all patients would require endoscopic therapy, but if one is symptomatic or if someone has complications like infection, bleeding, rupture, or fistulization to adjacent structure, then you would require intervention. If someone is having severe abdominal pain or pressure effect on surrounding structures causing symptoms, they would require intervention. While talking about intervention, we should also know when not to do EUS drainage. If the cyst character is not well defined, or if the cyst is away from the lumen and not accessible, one should not go for EUS drainage. If there is a doubt regarding the cyst, whether it is a cystic neoplasm, then you should confirm that before doing any procedure. If there is a complication like pseudoaneurysm, this should be tackled by interventional radiology before embarking on EUS drainage. The prerequisite for EUS drainage is a good imaging modality. It should be a combination of CT and MRI. MRI is preferred, especially a T2 weighted MRI, to see for the necrotic material. So MRI delineates the necrotic material much better. It also would give an idea of the nature of MPD. The varices or pseudoaneurysm can be well seen in a contrast enhanced CT. When you think of intervening in pancreatic fluid collection, then there are certain factors which should be taken into account. One is whether there is any amount of necrosis within the collection. If the
It's not playing.
if the necrosis is very less than 10%, you require only few sessions or may not require any further sessions after the initial therapy. The more than necrotic element, then you would require more sessions, especially for necrosectomy. This has been shown elegantly by Dr. Rana. So pancreatic pseudocysts are one which does not have any necrotic material. It can happen with chronic pancreatitis as well as acute interstitial pancreatitis or with disconnected duct syndrome. This pseudocyst is one which develops after 4 weeks of acute pancreatitis and has got a well-defined wall. It has been shown that the endotherapy has got equal success rate as surgery and less complications. So if a cyst is amenable to therapy, then endotherapy is preferred. It has got higher technical success rate compared to conventional drainage when it is done by endoscopic ultrasound guidance. And it also reduces the complications and avoiding
Anyone from the admin side?
of through which
Hello?
the puncture is done. While doing cystogastrostomy,
Anybody from the organizing
place
committee?
the stent, a double pigtail 7 or 10 French is recommended. There is no difference as per the number or size of the stent, and it is said that more than one would always be better. EUS guided drainage shortens the length of hospital stay and it is less costly than surgery. And it has been found that it gives better quality of life at 18 months of follow-up. You can also do lamps. It is easy to do, but it is very costly. And if one is placing a lamps, it should be removed within the next 4 weeks because there is increased risk of complications. Plastic stents, though more cumbersome to do, it is cheaper and it has got the advantage of being left alone indefinitely if there is a disconnected pancreatic duct syndrome and the outcome is at par with the lamps. Vault of necrosis is a collection which can be intrapancreatic or extrapancreatic location with well-defined wall. It has liquid and non-liquid contents and anything which happens more than 4 weeks after necrotizing pancreatitis. So there is an encapsulated wall, and wall may happen even before 4 weeks. But when you think of managing wall of necrosis, you should have a multidisciplinary team which includes an endoscopist, intensivist, interventional radiologist, and surgeon. The type of management of wall of necrosis has been depicted by various trials. And one of this is the tension trial, looked at endoscopic step-up approach versus surgical step-up approach which included a percutaneous drainage, followed by video-assisted retropancreatic drainage. This was a multi-center randomized superiority trial involving 19 hospitals in Netherlands. It was found that endoscopic step-up approach was not superior to surgical step-up approach, that is, it is equal in reducing major complications of death. And also the rate of pancreatic fistulas and length of hospital stay was lower in endoscopic group. Another trial, that is a MISER trial, looked at minimal invasive surgery versus endoscopy. It was found that the endoscopic transluminal approach reduced major complications, lowered cost, and increased quality of life. So, endoscopic therapy is better with less complications than surgery. Can it be done before 4 weeks? Yes, the encapsulation might happen in a small percentage, but it is associated with increased risk of mortality and increased risk of surgery. The other factor which dictates the type of drainage is whether the patient has got multiple collection. If so, a multi-gate approach would be required. If the collection is away from the endoscopic axis, dual or percutaneous drainage or ward or surgical minimus drainage might be required.
I have informed Dr. Avinash, probably.
If there's a disconnected pancreatic duct syndrome, which is
they said that they are able to watch there,
frequently in wall-off necrosis,
but it's not coming here.
From Sandeep's group,
are you able to see, Prakash?
About 73.8%,
able to see.
About 74%.
Not able to see.
Ravi?
Is the cause for disconnected pancreatic duct syndrome.
I am able to see, sir.
You are able to see the presentation.
Yeah, sir.
Of pancreatic fluid.
I also can see.
97% of them.
No, here actually Prakash is not seeing. I am not seeing.
I am able to see.
It is said that
okay, present then.
long-term plastic stent after drainage would help in these patients. Endoscopic drainage include EUS-guided transgastric puncture and placement of stent. This may be a plastic or fully covered SEMS or LAMS, or along with a nasocystic drain for irrigation, followed by a direct endoscopic necrosectomy. Whether a metal or plastic stent is best for pancreatic fluid collection drainage, this has been looked at by a study from Shyam Vadrajalu's group. It has found that there was no difference. It has been found later on that EU-specific metal stents reduces the duration of procedure easier, and it makes the direct endoscopic necrosectomy easier and with better clinical efficacy and lower morbidity. But this comes at a higher cost of procedure. The necrosectomy can be done at the time of the index intervention, especially if placing lamps and if it is more than 40% necrotic material or poor drainage of cyst contents. The second intervention can be done. It can be done as a second intervention if there is non-resolution of world of necrosis or persistent symptoms. The complications of necrosectomy include bleeding, perforation, pancreatic fistula, or infection. The overall complication rate has been documented as 36%. The complications happen when the stent is placed for more than 4 weeks, and if it is more than 14 days, then the risk increases. So the adverse events were looked at in a trial from the Shyam's group again. It has found that pancreatic fluid collection, if it is less than 7 centimeters, and if the removal is after 4 weeks, then there is increased risk of adverse events. To prevent the complications, the lamp should be removed within 4 weeks, and placement of a double pictate stent through the lamps would help prevent the complications. Should a transpapillary stent or ERCP be required? If transmural drainage is performed, an addition of transpapillary drainage seems to add no benefit, and ERCP is not routinely required. If one wants to see whether there is a disruption of the pancreatic duct, a secretin enhanced MRCP would be better. Insertion of a stent across a partial MPD rupture is the indication for ERCP, but it succeeds only in 33 to 67% of the patients. How to follow up these patients? The specific timing is lacking. These patients can be monitored for any increase in any new symptoms, organ failure, or signs of sepsis, or signs of local complications. And to follow up these patients, CT is the imaging of choice. When should one remove the stent? LAMP should be removed by 4 weeks. If it is stent in pseudocyst, it consider removal by 6 weeks after regression of pseudocyst. A secretin enhanced MRCP is advised prior to removal. If no ductal disruption, this stent can be removed. Is disconnected pancreatic duct syndrome, a long-term plastic stent placement would help. When would surgery or percutaneous drainage is required? If the collection is inaccessible endoscopically, or if there is complications during procedure, or if there is failure of endotherapy. So, how to summarize, to give an algorithmic approach in patients with pancreatic fluid collection, can be either pseudocyst or walled-off necrosis. In pseudocyst, a plastic stent would suffice. In walled-off necrosis, depending on the collection, or a pancreatic disconnection or flank extension, a dual modality may be required. And for walled-off necrosis, LAMPS is preferred than a plastic stent. To summarize, pancreatic fluid collection, consider intervention in symptomatic or patients with complications. Endoscopic step-up approach is associated with less complications. EUS-specific stents are preferred, especially in walled-off necrosis. Thank you.
हेलो
हाँ सर, वो दूसरा वीडियो सर
हेलो
कंटिन्यू रखो सर, वीडियो कंटिन्यू रखो. हेलो.
हेलो
हाँ सर.
Yeah, I think we will finish the presentation of Dr. Sandeep.
हाँ सर. Dr. Sandeep, continue sir.
Dr. Sandeep, I think now I would like to call upon Dr. Sandeep, who is an eminent, I think Endosono goes in word with Dr. Sandeep. Dr. Sandeep, you are going to tell us how I do endoscopic ultrasound guided drainages, plastic stent, metal stent, what are the precautions we should take. Over to Dr. Sandeep.
Hello. Sachin, I have Dr. Sachin.
Yes, ma'am.
Hello.
Hello.
Good afternoon, everybody.
Yes, sir.
At the outset, I would like to thank Dr. Manoj Sahu and his entire team for organizing this midterm SGI Endocon. In this session, I will be speaking as a topic on the slide you can see is EUS guided drainage of pancreatic fluid collection, how to do it. In this technical talk, I will be speaking on the steps of drainage of pancreatic fluid collection and when to decide how to use a plastic or a metal stent. As we all know that pancreatic fluid collections are broadly classified into two when they are mature as either pseudocyst, which do not have any debris, and walled-off necrosis or WON as they are commonly called, have debris inside the fluid cavity of variable percentage. As you can see on this screen, the two small videos which are playing are showing huge collections. The one on the left panel is a pure pseudocyst, does not show any debris, and so is the one on the right panel, which shows a large collection which is on almost a U-shaped, And also you can see a little bit of pancreas with upstream dilated pancreatic duct. So both these collections are pure pseudocyst. We can also see by EUS some of the collections which are bilobar, or they have a minimal communication between the two, and sometimes we can also see collections which are extending into the mediastinum, as you can see in this MRI. What we want to know during EUS assessment is whether the collection has debris or not, as you can see in both the images, and are there any interposing vessels. So these are some of the important things before we take a decision of EUS guided drainage. And why we do EUS guided drainage is that EUS helps in improved localization. It helps in visualizing and avoiding interposing vessels in the wall of PFC when we are draining them. Select the best point of entry, which is generally the thinnest point that we choose, especially if the scope is in a straight position without any loops, and the point of entry should be as dependent as possible. So these few things we take into consideration before we decide where to drain from. And it also enables us to drain collections which are non-bulging in the stomach or duodenum or esophagus. The only drawback compared to a duodenoscopic guided collection drainage is that the channel diameter is 0.5 millimeter lesser. Here it is 3.7 in EUS, whereas a therapeutic duodenoscope has 4.2 channels. So a 10 French stent, if you want to place, has its challenge to be passed across. So let's go to steps of EUS guided drainage of the pancreatic fluid collection, and I have divided this into 5 steps, and the first step is further subdivided into smaller steps. So before we do anything, we inspect the collection. So that's a very, very important point, to know for the maturity of the collection, to know what is the content inside. For example, on the left side you see purely liquid, but a little bit of debris also inside. You want to measure the longest dimensions, both in anteroposterior and laterally. Measure the wall thickness. Also find out what is your scope position, because then your ease of accessories will be different. If it's in a long position, it will be more difficult to pass your accessories in and out. Look for the vessels, so Doppler has to be checked, and then finally select the point of entry where you would like to go. If you're going from the stomach, it is always preferred to use the posterior wall so that it is directly into the lesser sac, or the superior part, which is the upper part of the lesser sac. But if you're hitting anteriorly on the stomach, then there's a risk of perforation. So having done the inspection, as we do it now, you see the variable amount of debris. So on each frame, the debris quantum looks different. So you have to make an overall assessment, and this is what we mean by measurements. So the two lines should be perpendicular to each other. That gives a pure measurement in 2 dimensions. Having done that, then we make a puncture into the collection, and the standard way we do is a 19 gauge FNA needle. Also we can sometimes use cystotome, which Europeans generally prefer, 10 French, 6 French combination cystotome. But whichever way you enter the vault of necrosis or pseudocyst, after puncture we need to take out the fluid for analysis. So, and that you can also inspect whether it's pus, pure fluid, turbid fluid, and so on and so forth. It's sent for analysis. Some people do inject contrast, but personally we don't at our center, for the simple reason that this can add to the risk of infection and doesn't give any extra advantage. The third step is, and these are the several needles that you can see on the screen, each needle is equally good, and there is no extra advantage with one needle over the other. Whichever you are comfortable with FNA, you can use that needle for initial puncture if you're using FNA needle for puncture. So there are alternate methods of access to the pancreatic fluid collections, and these can be either direct puncture using a flexible soft cystotome, which I mentioned earlier, 6 French cystotome with a combination of 10 in the same assembly can be used, or some centers prefer needle knife, but this is a very dangerous equipment to be used for access. I will explain it later. And whichever way we enter, we aspirate the fluid after removing the stylet, and this is sent for analysis or cultures and so on and so forth. So if you see the devices for access is needle or cystotome or needle knife. So these are the current requiring devices, and these are mechanical needle type devices. The advantage is that it is visible. You can easily transmit your force from the handle to the tip. But the downside is it's rigid and sometimes it gives a tangential puncture. There can be shear of the wire. The advantage of cystotome or needle knife is it's flexible, you can adjust the angle, and cautery allows easier penetration, although needle also does the same. But the downside is they're not so well visible and they may change direction when you enter. Plus there can be cautery trauma. So these are the downsides. So it depends on your experience or your center's experience, but personally I prefer a needle for entering the collection. Then we go to the next step is after aspirating the fluid, we pass a guide wire inside the collection, which can actually be seen on EOS as well. You can see it coming and coiling inside nicely. And if you want to be doubly sure that the wire is nicely coiled, you can use a fluoroscopy to see that at least 2 or more coils are made in a small collection, but a large collection, one single coil is good enough. And the wire that we generally prefer is 035 or a 025 inch long guide wires. My personal preference is to use a little angle tip wire rather than a straight wire, for the simple reason that if I use a straight wire, it hits the opposite wall and the wall is not mature, it can perforate and go beyond. Whereas an angle tip wire, even if it hits the opposite wall, it doesn't give so much of a pressure or a puncture, and it can bounces off even an immature wall. So that's an advantage. This is what I meant by a straight wire and an angle tip wire. So once you have the guide wire well inside, then you withdraw your needle, leaving the guide wire inside, and this movement with your has to be in a coordinated fashion with your technician so that you accidentally don't pull out the wire, because then we have to start all over again. The next step now is creating a cystoenteric fistula, depending on which site you have entered from stomach, esophagus or duodenum. And there are two ways to do it. Either you do mechanical dilation, that is you use over this wire a tapered catheter or a bougie or a stiff balloon. All can be used. Or we can use an electrosurgical devices like a cystotome, 6-French cystotome, which goes over the guide wire, as you can see it here, like this one. And some people use needle knife, but again this is fraught with danger. As you can see, the needle knife can go in a different direction compared to where the guide wire is. So you can go tangentially and cause dissection of the wall and cause even bleeding of the vessel which are not visible. Staying with the mechanical dilation, we can either use bougie and balloon. As the name suggests, bougies are tapered catheters, which can be in the same catheter. You can have several diameters, or you can use several types of it. Balloon is another way, a 4 or 6 millimeter short balloons which are stiff and they can go down easily inside the cavity. So the downside of balloons is perforation and bleeding can happen, and downside of a bougie is that axial force may sometimes dissect the tissue planes. But my favorite is a 6-French cystotome, which is passed over the guide wire. It is coaxial, follows the guide wire, and sometimes it can be challenging in long position, but nevertheless it goes in fairly well. Needle knife I would always resist from using unless nothing else is available. And these are the examples of how it looks like. Here the guide wire is inside and a cannula, tapered cannula is being pushed in. A tapered cannula does not have enough stiffness, but if the wall is very thin, it can go in, or you can use a stiffer bougies. The right panel shows the guide wire with a cystotome going in. Almost always works. And the third step is to dilate now this fistula with a balloon, which can vary in caliber depending on where you have entered from. In stomach, we use 10 to 15 millimeter balloon. For esophagus, 4 to 6 millimeter balloon should be okay. For a duodenum, 6 to 8 millimeter balloon. You can also see the balloon on EOS, and if you fill with contrast, you can also see on fluoroscopy. But that's often not required. EOS is generally good enough. It tells you that you're inside, and if you have any doubt, you can just pull back your scope and distend the stomach a little bit. You can see the balloon fully inflated across the wall. The last step here is placement of the stent. For a plastic stents, we use double pigtail. Never use a straight stent, and always place more than one stent. 2 or more stents are preferred, and if you decide to place 2 stents, it is better to place 2 guide wires before and then start placing stent one by one. And how do we place 2 guide wires? You can either use a double lumen cannula or a 10 French pusher tube which can accommodate 2 or 3 wires, or sometimes a loop wire is passed over the first wire which is placed. And once you have both the wires nicely inside, coiled inside the collection, Then we place the 7 French is our preferred size caliber, and the length that we use is 4 or 5 centimeters long. Here I would like to tell you that most of these stents do not have a radio opaque marker. It is best to put a radio opaque marker in the center of the stent, which will tell you that it is now going in inside. So the aim is to keep half the stent inside the collection, as you can see on the screen, and half the stent in the gastric lumen. Try not to push 3/4 inside and 1/4 in the stomach. This is a very important slide which I would like your attention on. Which imaging is used in which step? So at the inspection level, we only use EUS, very logical. For puncture, it is only EUS image. We don't use fluoroscopy or endoscopy. For passing the guide wire, we use EUS definitely. We can use fluoroscopy if you're not able to see the wire on the EUS image or you're not very sure. The next step of passing a cystotome, again EUS tells us almost the entire steps, but if you have a doubt, you can cross check on fluoroscopy. The next step of balloon dilatation of this fistula, you can do everything on EUS as I showed in one of the videos, but you can also use fluoroscopy when the contrast is injected inside the balloon, and you can cross check with endoscopy if you are not sure whether the balloon is little bit outside the lumen, outside the wall of the entry point into the stomach. And last but not the least is the step of stent placement. In either case, metal or plastic stent, whichever we use, we definitely use EUS image to see the inner flange or the inner part of the stent going in, and endoscopy to see the gastric end of the balloon, or fluoroscopy to see the inner flange, and then the gastric side is seen by the endoscopic view. So combination of EUS for the inner end of plastic or metal, and for the gastric side endoscopic view or fluoroscopic view if you're leaving the stent inside the channel and then pushing it out. Then comes the step of walled-off necrosectomy, walled-off necrosis, which may sometimes require necrosectomy. And this is generally done for patients who are not improving with the standard management. That means you have placed the stent, fluid has drained out, but the patient remains symptomatic or still continues to have fever or develops a new onset fever. This means that the debris inside has now got infected, either because of procedure or because now you have made it communicating with the bowel. In that case, we need to take out this dead tissue, which is a good culture ground for the bacteria to grow. And in endoscopic necrosectomy, we take the endoscope inside the cavity. It's a very labor intensive procedure, can take half an hour to 45 minutes or sometimes even an hour. They are high risk procedures, can have complications. And that's where the role of large caliber metal stents have come into picture. These LCMS or large caliber metal stents are broadly classified as LAMPs, which you all know, or luminoporsing metal stent. Axios and Spaxis are the two important stents in this category. And biflange metal stents, which are excuse me, are stents which have flanges, but they are a little longer than the exact wall of the collection, and they don't oppose the two lumens in which they are placed. Just keep the lumen patent and allow the debris to drain out from the content of the cavity into the lumen. Nagy stent is the commonest type of the biflange stent that we use. Let me show you an example of how a Nagy stent is placed. The initial steps remain the same. You puncture, pass the guide wire, pass a cystotome, pass a small caliber balloon. This is a cystotome going in, and then we dilate this path with a balloon. The aim is that the assembly, which is about 10.5 French, can slide in easily. So this is a 4 millimeter balloon. 4 or 6 millimeter generally safe. This is not meant for draining the collection, but mainly meant for allowing the assembly to go in easily. And once the stent is inside, here we are deploying partly under the endoscopic view and partly under the EUS view. So this is the gastric side deployed, and you can see the nice position of the inner end. And these stents expand with passage of time. Over next 2 to 3 days, they will reach their intended diameter that they're supposed to. And now we prefer a 16 millimeter, the largest caliber available, which can be seen both in endoscopy, fluoroscopy, and on EUS, like a bow shape. And these collections rapidly reduce in size. They drain very efficiently. All these stents are equally good. In case the debris inside and does not drain out the solid component, and the patient develops some symptoms, then we need to re-intervene. And endoscopy at this stage becomes very important. So a person who is getting a new onset some symptoms of pain or fever, or his symptoms have not subsided and you had an index procedure, some debris inside, then it is good to do an endoscopy after doing some kind of imaging, CT screening or ultrasound. And during endoscopy, often we find that the loose debris, which is large in chunk, bigger than the diameter of the stent, can come and clog it. And these can easily be teased out by several accessories. And the braided snare is our commonest accessory that we use, which holds this loose debris, catches it well, and then takes it out. And that's the job done. So the stent which was blocked now has become unblocked, and all the fluid can then drain out. There can be many more debris inside which can then block. So you can actually quickly peep after removing this clogged debris. See inside how the cyst cavity looks like. Is the granulation tissue present? If there are more loose debris, you can do at that procedure itself, remove all of them. If the debris is stuck to the back wall of the cyst and not coming out easily, and the patient requires some kind of an intervention, then this may be a good idea to place a nasocystic tube, because an adherent large debris, it's a labor intensive procedure and may not do justice just by spending time and nibbling out those adherent debris. So it is best to just irrigate with hydrogen peroxide or saline or a combination of two. We generally prefer saline, but if somebody has an infection inside, then we pass hydrogen peroxide also 8 hourly, 10 to 20 ml. The last step is to actually physically remove this debris. In this patient, as you can see, a lot of pus is coming out and he has symptoms. So this was removed by the snare, going inside the cavity, catching bits and pieces and then taking it out. Hot axios is now the current standard in most of the parts of the world, where you place this very super efficient stent, lumen opposing stent, and this is where we prefer in patients who have significant amount of debris, where necrosectomy is almost always required. And once you see the collection, we pass the device, which has 4 steps marked on the assembly itself. The first is puncturing with high cautery intensity, pure cut or auto cut mode of 100 watts, avoiding the blood vessel in between, which is what I'm doing now. And once we are inside, then we go to the second step of releasing the inner flange. As you can see it here, the inner flange has got released. And then we go to the third step and we pull back the sheath of the assembly so that the stent inner end gets little deformed. And then we deploy the gastric end of the stent, which can be done endoscopic view or directly in the channel. If you see this black marker here, then you can do it endoscopically, and you see a frank pus draining out in this patient. So these are the animation of this is the animation which shows how the stent is deployed. So inner end flange deployed, and these are very easy to use methods, the steps. After first few stents placement, then you understand that what is the logic of all the steps. Very nicely designed stent. So the advantage of large caliber metal stents is that they are easy to deploy, very high technical success. They are large diameter, so drain very efficiently. They are fully covered, so prevent any leaks and perforations. They are self-expandable, so prevent any entry side bleed. And as they expand, the fluid keeps draining, and so does the solid debris if it's loose. The design is saddle shaped or biflange, which reduces the chance of migration. And re-intervention through the stent can always be done using a forward being regular endoscope. There's few disadvantages also of these stents. Sometimes malpositions can occur. There's a very short gap of what you call margin of error. So malpositions, if it occurs, then the whole stent you have to remove and use another one. So that comes the cost. Bleedings can sometimes occur from the vessels on the opposite wall of the collection, which happens when the stent is deployed, the fluid drains out, which is initially working like a cushion, and once the fluid drains out, the back wall comes and hits the inner end of the stent, and that may have vessels inside, and that can cause bleeding. Migrations can happen either spontaneously, more often with biflange metal stents, but can also occur with the lambs as well. or at the time of direct endoscopic necrosectomy. Also at then we can sometimes, these stents can be hindrance to the view, and then we have to remove it and replace it later on. So which stent to use, metal or plastic? If it's pure fluid collection without any debris, that is pseudocyst, then plastic stent is better, equally efficient and safe. Those vault of necrosis which have minimal debris, and that estimate, if you make at the index procedure of drainage, say 10% or 20% or less, you can safely put those plastic stents. But those which have high amount of debris, 30%, 40%, 50%, and they have to be drained, I think a metal stent is justified at that point of time. So there's a gray area between 10 and 30%, but less than 10 you can do with plastic. 10 to 20 to 30 you can choose whichever is available and the cost constraints. But above 30% of debris in the overall scenario of the collection, a metal stent is better. This is one such example of a necrosectomy through a metal stent. This is a Nagi stent. Now you can see the debris which is large clogging inside. So you tease it out, push it in gently, get a good favorable anatomical orientation of the debris, and catch it with a braided snare, which is a preferred instrument to remove the debris, both from the lumen at decoggling and also at the time of removing from inside the cavity. And sometimes you may be lucky enough to get a very large collection hanging out. Almost entire debris has come out. So in the end, I would like to sum up by saying, take home message, that metal stents should be used for one with significant debris. Plastic stents should be used for pseudocysts or those with minimal debris. Re-intervene only based on symptoms of the patient, example persistent SIRS or new onset symptoms. And re-intervention procedures can be several. It can be cleaning the stent lumen, lavaging the cavity, doing direct endoscopic necrosectomy, or sometimes multiple gateway technique or sinus tract necrosectomy. And last but not the least, surgery in case the patient is not improving at all. One must remember to remove these metal stents after a finite interval. They should not be inside for more than 3 to 4 weeks. This you must ensure to the patient that it has to be removed, whereas the plastic stents are much safer and can be taped for a long time. Thank you very much for your kind attention.
Good afternoon. Hello,
Hello.
Dr. Srinivas.
Yeah, Dr. Ravindra.
Any questions to both of them, Dr. Prakash and Dr. Sandeep?
My question to Dr. Sandeep is, given a choice, what is his take on multi-gate technique?
Dr.
What's the
Sandeep?
SEMS? What's the SEMS?
If Sandeep is not there, Prakash can take up.
Yeah, Prakash can take it.
Yeah. So if multi-gate technique is something which can be used when there are large multiple cysts or a very large cyst where the drainage seems to be inadequate. So in that situation, multi-gate technique would allow better drainage of the pseudocyst.
No, in case of one, would you, will it directly, because there are some advocates of multi-gate techniques even for one.
Yeah.
Do you prefer that, or directly a metal stent would be better?
See, in our situation, there is an issue of cost because lamps is something which is very costly. So we have to have, in our situation, those patients who cannot afford lamps, multi-gate technique is one thing which can be used. But the other one which can be used is placing a nasocystic drainage along with the stent, which will help the drainage of or the removal of the debris. Because multi-gate technique is something which might not be very easy, especially if your window is not that great, especially while doing US. So the other option in our situation, when a patient cannot afford lamps, is to place a nasocystic drain and lavage along with the stent.
Dr. Satyaprakash, sir, any questions?
Yeah, Prakash, you were mentioning that, the EUS guided placement of lamps is little superior to ERCP guided procedure, because earlier before EUS we are all doing the ERCP guided procedure. Apart from the technical, you are also mentioning about the cost factor, which is little higher with the EUS guided procedure. Taking away the cost factor, what are the disadvantages or advantages? Because we have more people doing ERCP guided procedures rather than EUS guided. Any specific precautions you advise, or you just totally go against placement of metal stents through ERCP scope?
Yeah, your point is something very, very much relevant. We all have been doing ERCP, just blind procedures, but blind procedures should be left for patients who have a real good bulge. So if you don't have a good bulge, then it is better not to venture into a blind procedure that is just ERCP guided, but using the side beam scoping. If there are, and another thing is, prior to the procedure, when you do an imaging, if there are a lot of varices, then this should not be considered at all. So if the cyst does not produce much bulge, then EUS guided procedure is the way to go. And also, if you feel that if the cyst is slightly away and it is accessible, then also EUS guided procedure is the one which should be involved. And EUS, another important thing is that you can see you can avoid vessels on the wall while doing the procedure, which will not be possible when you do just a blind procedure with the ERCP scope. So that is something which should be taken into account. So with all these advantages, if there is a bulging, really good, mature cyst without any varices, without any pseudoaneurysm, even now you can go for using a normal side wing endoscope and do the puncture. But
Thank
these
you.
are the.
That's nice.
Dr. Matthew, sir, anything to add?
Not much, because they have covered everything and both the presentations were excellent. And I just want to only tell the people who really want to start the procedure, definitely they should be knowing the accessories very well, because doing with hot axios, if you are not very familiar with the mechanisms or technique, or at least your technician should know very well. And at least in one instance, I know that there was a technical issue, and finally there's a technical fault of the hot axios, and then we had to struggle for that. So these are all very important, but I think the hot axios is really an excellent device at present, except for the cost in patients with Waldorf necrosis. I think that is a very easy one-step procedure.
Dr. Sandeep, you are there? Dr.
Sandeep is not seen. Sandeep is not seen.
Sandeep is not seen in the panel, yeah.
Can I ask a question?
Hello, can you see
Yeah,
me?
please.
Okay, Suganya, carry on.
Dr. Sukanya, please.
Yeah, thank you. I just wanted to ask to either of the speakers, how soon after a coil embolization can a drainage of cyst be done?
Dr. Sandeep?
It's a tough one. Yes, can you hear me?
Yes.
Sandeep, welcome back. Wherever are you?
I'm here only, but there were some technical glitches, so I could not log in. I could hear my lecture, but some of the questions and comments I could miss out. So thank you for that question. I think that's a very tough one, and there's no right answer for that. But there is some experience from PGI Chandigarh, and Surinder Rana has published on it. And those patients who have
We are not able to hear you, sir.
Hello? Dr. Sandeep, you are not audible. Dr. Prakash, can you take this question? How soon post pseudoaneurysm coiling, you can do the pseudocyst drainage.
Prakash?
Hello.
Yes, we are hearing you. Tell.
Sorry. Hello.
Yes.
So on this question of aneurysms, and we have to take care of aneurysms first. In at least a week or 2 weeks should be waiting before we drain the collections.
Okay.
After tackling the aneurysm by intervention radiology.
Right. Right. Thank you.
What is the role of irrigation of the cyst? Is it mandatory that you take care, or unless you find the solid material on the MR, you take care? Because you don't inspect immediately the cyst after placing a stent. Is it a routine procedure to irrigate the cyst after placing a stent? Prakash or Sandeep?
So if I can.
Sandeep, you are not audible. Dr. Prakash?
Yeah. So the thing is, after placing a stent, if there is large amount of debris, like if it is more than 40%, then there is a group of, there is a thought that a direct endoscopic necrosectomy at the index procedure itself may be helpful in some. But at the same time, there is a thought that it might lead to complications. But when you are placing a lens, this may not be there. But if you are not inspecting it, then, and if the previous imaging showed lot of debris, then some kind of flushing can be done by placing a nasocystic drain. But usually this hydrogen peroxide and all would be done after clearing the most of the debris. You instill the hydrogen peroxide into the cyst, but that would help in removing the rest of the debris.
Prakash and Sandeep, and can I ask a question? Suppose a patient he has got an infected pseudocyst, because you puncture and see the pus is coming out. Any other precautions you want to do? Sandeep or Prakash, because it was not diagnosed early, and you puncture and you find out that the what you get is frank pus. What will be your next option?
So
the question is, will you put a nasocystic drain?
Yeah.
Will you always put a expandable stent for that?
So when you have an infected pseudocyst, then it would be better to drain out the whole thing. So in such a situation, a large caliber metallic stent, if you can place, that would be very helpful. Or you can place a nasocystic drain along with the stent.
I think Dr. Matthew, if we are right, we should put, if the patient is affordable, put 2 plastic stent and a nasocystic drain as well, so that it drains out. If patient is affordable, put a metal stent, but also we should put a plastic stent inside, because many a time this metal stent gets clogged and then they can get infected.
No, what I want to say is that if you are putting only plastic stent, always put a nasocystic.
Yes.
Otherwise, it will be dangerous. Okay, Prakash, you are trying to say something.
Sir, can I ask a question?
Yeah, please.
Sir, I just want to know what is the technical difficulty just we encounter when there is a left-sided portal hypertension associated with severe portal hypertensive gastropathy. Is there any special precaution we have to take, because there will be collaterals beneath?
That's right. So when there is a portal hypertension which has been documented prior to the procedure, then you should be very careful while doing a procedure, because there can be varices, there can be vessels in the wall. So you should do the procedure only under EUS guidance, even if there is a good impression by the cyst. Don't do a blind puncture of the cyst. That is the most important thing. So you should do an EOS guided puncture only, and try to avoid these vessels and choose a good position where there is which is free of these vessels.
Sir, one comment, sir. Since many postgraduates and DM residents are there, the important thing when you do any US, the close approximity, the approximity should be less than 10 millimeter, that is less than 1 centimeter. And other thing what you have to see is the thickness of the cyst, means the capsule, what is whether it is matured or not. Then the third component is the content of the cyst. So before doing any procedure, there should be a good approximation, especially you're doing a cystogastrectomy, there should be a good approximation to the wall of the stomach. So the distance should be less than 10.
Yeah, I think any good suggestion. I think if because we have already crossed 4 minutes, it is 2:34. I thank both the speakers, Dr. Prakash and Dr. Sandeep, for enlightening us how we do and when we should do the endoscopic pseudocyst drainage or WON. And once again, I thank Dr. Sahu and Dr. Avinash, who are in the COVID times. It's very difficult with all these technical things to do this. And I thank both of them for doing a wonderful job. Thank you very much.
Thank you.
Bye bye.
Thank you all.
वेबिनार स्टार्ट होगा, बट अभी बात कर सकता हूँ मैडम।
ಹಲೋ, ಏನು ಏನು ಹೇಳಿ? ಟೆಲ್ ಮಿ ಫಾಸ್ಟ್. ಐ ಆಮ್ ಬಿಸಿ, ಕಾಲ್ ಯು ಲೇಟರ್.
Should we join?
Evening, sir. Dr. Rajesh.
Yes.
Dr. Rajesh, how are you?
So should I share the screen?
Sure. How do we? We have another 5 minutes, I think, to go. 4 minutes to go, I think.
We can share the screen, I suppose.
Wait 5 minutes, sir.
Okay.
Should we share the screen?
5 minutes wait, sir.
Okay, we wait 5 minutes. Okay.
Hi,
How are you? Good, sir.
Nice to see you virtually. It's a long time we haven't.
Yes, sir. Long.
Hi, Dr. Rajesh.
Surendra,
Nice.
Sir,
you are going to talk the biopsy part and I am going to talk about the morphological part.
Sir, whatever I was supposed to talk, I have already spoken.
You have given lecture?
It's recorded.
Okay.
Oh, okay.
No,
Hello, sir.
I discussed with Manoj Sahu because
I have spoken only on FNA, nothing else.
Yeah, and I'm only going to speak about
EUS.
EUS.
Hi, Chalpati, how are you?
Sir, good evening, sir. How are you, sir?
Hi.
I'm good.
Hello, sir. Hi, Dr. Sharma.
Hi. Hi.
Hello, sir. Puri, sir.
हाय
Hello, sir.
थोड़ा सा पढ़ लेते हैं यार क्वेश्चन पूछ रहे दिक्कत होगी
Hi, Dr. Satish. How are you?
Hi, Dr. Satish. New look. Yeah, you're muted. You're muted. Hi,
Yes,
Dr.
new
Pradeep.
look.
Hello. Hi. Sir, you got the shot of vaccine. I think today in PGI it started.
No, it has been going on for the last 7 days.
Okay, okay.
हेलो सर आप मेरे से 1.5 घंटे बाद बात करें
We are ready to start. We can start. Javi, could you play? Dr. Puri sir, you would be sharing your slides, or do you want us to share?
No, we will. I will share, but somebody else is. You cannot start screen while others are participating sharing. Somebody else is sharing. You have to tell them to.
Yeah,
Sir,
we'll
now you can share the slides.
Yeah, sir, we can see your slides.
Can you make it bigger? Slideshow. Can I just check it? We have time for 1 second.
Yeah.
ये साइड का नहीं हट सकता ये एक मिनट रुक जाओ चलो मैं हटाऊं Can you remove this side one? साइड वाला छोटा कर सकते हैं Am I visible there? Am I audible?
Yes, sir.
So whenever you will say, we are going to start.
So we are good to start.
I think chairperson's here. Good evening to all. I think we'll start this session. This is about the role of EUS in subepithelial lesions, submucosal lesions as it's been termed. I think the first talk for this will be by Dr. Rajesh Puri. Needs no introduction for the EUS group. Is chairperson and chief of endoscopic ultrasound unit in Vedanta Hospital. To start off, let's look at the role of endoscopic ultrasound, the diagnostic imaging in subepithelial lesions. Over to Dr. Rajesh Puri, please.
Good evening, everyone. First of all, I would like to thank Dr. Manoj Sahu and the entire organizing team for giving this opportunity. And I would like to thank Chairperson for giving the kind introduction. As my Chairperson was also talking about the role of EUS in submucosal lesion. So what I'm going to talk about, what is an importance of endoscopic ultrasound in the subepithelial lesion. And first of all, it is very important. Should we talk about, is it the subepithelial lesion or they are submucosal lesion? According to the ASG guidelines, subepithelial lesion is a preferred term because when you talk about submucosal, it appears like it is originating from the third layer of the gut wall. So when we describe in our endoscopy, we should always describe as a subepithelial lesion. Mostly they are present during a routine endoscopic examination. They present as an incidental finding. You are doing endoscopy for some purpose. While doing endoscopy, you pick up and you are not very sure what kind of subepithelial lesion it is. But they can present in subset of group as a GI bleed or dysphagia or obstruction and other symptoms. The estimated incidence is around 1 in 300 endoscopy. The majority of them are small, less than 2 centimeters in size. And mostly subepithelial lesions are benign like pancreatic rest, lipoma, leiomyoma, or schwannomas. But 18 to 15% of the cases, either they are pre-malignant or they are malignant in nature, like malignant GIST or metastatic disease. So 10 to 15% of the individual, they have either a pre-malignant potential or they are malignant in nature. And it is important for us to know this group of the patient, and we EUS help in finding out this kind of lesion, which help in making the patient treatment at the right time. How can we evaluate the subepithelial lesion? As I said, mostly they are picked up on endoscopy or endoscopic biopsies, followed by endoscopic ultrasound, either done with the radial, linear, or forward viewing. And if required, you can take the tissue diagnosis EUS guided. Endoscopy, as I said, is the first evaluation because they picked up on routine endoscopy. And on endoscopy, you can roughly assess if there is a significant intraluminal component is there. Then you can assess the size of the lesion. If there is a no intraluminal component, if they are intramural or extramural, then it is difficult to assess the size on endoscopy. Again, shape can be assessed if there is an intraluminal component is there. Mobility can be assessed. Consistency by poking with the either with the biopsy forceps, you know about the consistency, pulsation over it, color, and the mucosal appearance sometimes give the idea about the subepithelial lesions. If the mass is ulcerated, you can take biopsy. Location sometimes also help. The nature of the lesion can be decided, but with an endoscope, it is difficult to differentiate an intramural lesion from the extramural. So in a bigger way, endoscopy has a poor specificity. Yes, you may be able to diagnose, the sensitivity is reasonably okay, but specificity of endoscopy for diagnosis of subepithelial lesion is very poor. If you get an umbilicated lesion in the first part of the duodenum or in the stomach, you may say that yes, this could be a carcinoid. If you find in an esophagus molar tooth appearance, then you can say it could be a granulosa cell tumor. In fundus, if there is a pulsatile or the bluish coloration with patient has an underlying chronic liver disease, then possibility of a fundal varix. And if you get a yellowish soft lesion in the colon, which has a pillow sign on pinching with the biopsy forceps, the possibility of lipoma is there. But yes, it can give idea, but they are not accurate for diagnosis of the lesion. The question comes, should we biopsy all subepithelial lesion? Generally, the mucosal biopsies are not sufficient for diagnosis, and cystic and the vascular appearing should be avoided. Possibility of bleed can happen in patient of GIST, and those lesions which appear solid or ulcerated, you can biopsies. So if you are not very sure about the nature of the subepithelial lesion, I suggest it is important we should not take the endoscopic biopsy. Either you are getting the mucosal component, or the patient, if it is a vascular or it is cystic, the chances of bleed and the rupture of the cyst is there. When we compare the EUS with the conventional imaging, these are two studies where the CT scan and the ultrasound was compared, and CT scan was able to pick up in 2/3 of the cases of the subepithelial lesion, while EUS was able to pick up subepithelial lesion in all. Similarly, with an ultrasound, the accuracy of ultrasound was 82% versus endoscopic ultrasound, which is 100%. And ultrasound can pick up extramural if the lesion is more than 3 centimeter, detection of the lesion if it is more than 2. So CT scan is mainly for the distant metastasis. With the CT scan, you may be able to differentiate about the extramural versus intramural, but as CT scan cannot give the layer of origin. So in 2021, for subepithelial lesion, I think the best test is endoscopic ultrasound, and if required, you can take the EUS guided biopsy. And why EUS is investigation of choice? Because it has the ability to differentiate intramural from the extramural lesion. The layer of origin gives the idea about the type of the submucosal subepithelial lesion. Echo level and the internal echo pattern of subepithelial lesion give fair idea about the diagnosis of subepithelial lesion. If patient has a local lymphadenopathy, you can take the biopsies. Doppler signals sometimes help to differentiate between a vascular versus non-vascular. If required, you can get that EUS guided tissue acquisition, which will be covered by my colleague, Dr. Surinder Rana. Elastography as well as contrast EUS also gives some idea about the malignant nature as well as the nature of the lesion, and you can do the targeted biopsies also. By this, it helps in determining the appropriate management of subepithelial lesion. The question comes, which scope should be used? So if the lesion is more than 1.5 to 2 centimeter, I think you can use radial or linear anything. But if the lesion is less than 1 centimeter or 1.5 centimeter, my preference is to use mini probe, especially if the lesion in the stomach. It is better to use the mini probe rather than using the radial and linear. If the lesion is large and this patient might require a tissue diagnosis, it is always better to use the linear echoendoscope, because it not only gives the characterization of the lesion, but also help in getting the tissue diagnosis. So this is on endoscopy, there is a submucosal lesion, but when you do an EUS, you see the spleen is compressing. So you can very well differentiate, are you dealing with the intramural versus extramural lesion? As I said, why EUS? Because with the EUS, you can find out the 5-layer pattern of the gut wall, and from which layer the subepithelial lesion is originating, you can predict the nature of the subepithelial lesion. That's why EUS score over other imaging modalities. Now, EUS, it differentiates a hyperechoic anechoic from the hypo to mixed echoic lesion. Generally, the hyperechoic lesions are lipoma or fibromas, which originate from the third layer. Anechoic lesions are full fluid filled, either they are vascular or non-vascular. So if you find an anechoic lesion, you put a Doppler. If Doppler signals are present, then it is mostly a ectopic varix, or if cystic lesion without any Doppler signal, the possibility of a cystic lesion duplication cyst is there. For hypoechoic, isoechoic, or mixed epithelial subepithelial lesion, the specific diagnosis is required because you want to rule out subepithelial lesion, especially the gist, which has a malignant potential. These patients require a tissue diagnosis. Now, a few tips about how to examine the subepithelial lesion with endoscopic ultrasound. What I do in my day-to-day practice, I do the two-step with the 7.5 or 5 megahertz. I do a gross examination, the relation from which layer it is originating, and using the high frequency, it is better to find out about the serosal involvement or adjacent organ involvement. It is important your scope should be perpendicular to the subepithelial lesion. Avoid tangential imaging. Put a water, avoid air. You can give Buscopan if you are examining the stomach. Do not compress the submucosal lesion or subepithelial lesion with your transducer or by inflating the balloon, especially the smaller subepithelial lesion. If you compress, it is very difficult. Similarly, in the duodenum, it is very difficult to know about the layer of origin. If it is compressed with your scope, it is very difficult. And for layer of origin, it is always better you should start with the transition zone from normal mucosa to the disease mucosa. Disease mucosa means we are talking about the subepithelial lesion. So from the normal mucosa to the subepithelial, that is called as transition zone. You examine from there to know the layer of origin, and that help in making the diagnosis. Now, how can we make the diagnosis on the basis of layer alone? Mainly from the second layer, you find the leiomyoma or granulosa cell tumor. From the fourth layer, if it is a cystic, then the possibility of the, and from the fourth layer, generally the gist, leiomyoma, or the schwannoma arise, or the glomus tumor arise. And when we talk about from the third layer, then there is a long list of lipoma, lymphangioma, fibroma, cyst, ectopic pancreas, and the brunomas, and the carcinoid tumor. Carcinoid tumor can originate from the second and the third layer. Similarly, leiomyoma can originate from the second as well as from the fourth layer. Generally, in the esophagus, if the lesion originating from the second or fourth layer, they are the leiomyoma, while in the stomach, if the lesion originating from the fourth layer, the possibility of the gist is very high. When we talk about on the diagnosis on the basis of internal echo pattern, if the lesion is subepithelial lesion is anechoic, the possibility of a cyst versus lymphangioma, or a vascular lesion, if the Doppler signals are present, then possibility of a ectopic pancreas, or a fundal varix is very high. If the lesion is hyperechoic, the possibility is high, which is originating from the submucosa, is lipoma. It is, I think, covered behind this bar, but the lipoma, which is hyperechoic, originating from the submucosa. So anechoic lesion are cyst, lymphangioma, or the vascular structure. If hyperechoic, the possibility of a lipoma or the fibroma, which is less hyperechoic, but the possibility is there. When we talk about the hypoechoic or isoechoic, you should compare with the fourth layer, or you compare with the liver and the spleen. The hypoechoic, mainly the carcinoid, gist, leiomyoma, leiomyosarcoma, schwannoma, glomus tumor, fibroma, and the ectopic pancreas. But in our day-to-day practice, we come across with the carcinoid tumor, gist, leiomyoma, and the ectopic pancreas. These are the 4 subepithelial lesions which we come across in our day-to-day practice. So I think the differential diagnosis on the basis of site, this is a list which is available in the books. You can read it. I'm not going to go into the detail. But yes, EUS also help in differentiating a benign subepithelial lesion from the malignant. If the subepithelial lesion, which is especially originating from the fourth layer, if it is more than 3 to 4 centimeter in size, if the margins are irregular, if you find a cystic species, which is heterogeneous ecotexture, exophytic component with the lymph node, and if they are non-round, non-oval in shape, the possibility of a malignant subepithelial lesion or malignant gist is very high. So if you see a lesion which is hypoechoic, originating from the fourth layer, which is more than 3 centimeter in size, irregular tumor margin, cystic spaces, heterogeneous ecotexture, and on contrast EUS, if you find a cystic spaces and the heterogeneous enhancement of the lesion, the possibility of a malignant cyst is very high. So what the data talk about us, what is the sensitivity and specificity of EUS? When we talk about EUS as a morphology, it gives the diagnosis in 45 to 83%. The accuracy is very poor. The sensitivity and specificity for picking up malignant lesion is 64 to 80%. So if patient has a 3 out of 5 features, then it is high probability that you are dealing with the malignant cyst. EUS guided tissue acquisition increases the diagnostic accuracy. Tumor size and the location are important factor in subepithelial lesion. Larger the size, higher the diagnostic rate. So EUS alone as a morphology is not very good. Roughly around 50 to 60% of the cases, it gives the fair idea about the diagnosis of the lesion. But to increase the accuracy, you require a tissue diagnosis. But definitely it is better than the CT scan or the MRI. Now I'm going to talk about the EUS feature of some common lesion, lipoma, which is soft and indented when you press with the biopsy forceps. That is called as cushion sign or the pillow sign. They are hyperechoic, homogeneous, originating from the third layer. And why it is important, if you find this kind of structure, then you know that this is a non-malignant and you don't require to repeat EUS. These patients don't require follow-up examination. So you have subepithelial lesion, which is hyperechoic. This is the musculus propria. In comparison to that, it is hyperechoic, originating from the third layer, no vascular signal, homogeneous. The diagnosis of the lipoma is there. You don't require to take biopsies and you don't require to follow up these patients. Similarly, if you find some lesion like this, which is tooth in appearance in the esophagus, that is called as granular cell tumor. Often they are mostly limited to the esophagus. They are generally small and they are hypoechoic, homogeneous, and originate from the second layer. Again, they are benign. The risk of malignancy is very low. You may not require to follow up with these patients. When we talk about the carcinoid, which originate from the second layer, I think the carcinoid can happen in the rectum, duodenum, and the stomach. They originate from the second and the third layer, and they are chromogonin and synaptophysin positive. They have a malignant potential. If you find a carcinoid in the duodenum or rectum, they require removal. And in stomach, the type 3 carcinoids is required to be removed. Type 1, I think you can wait. When we talk about the leiomyoma, they commonly occur in the esophagus. You see a submucosal bulge in the esophagus. They arise from the musculus mucosa, that is second layer, or from the fourth layer. Sometimes it is difficult to differentiate these lesions from the gist if they originate from the stomach, and sometimes they may come across with the calcification, and you take the biopsy, they are c-KIT negative and the Desmin positive. Similarly, if you find an anechoic lesion in the colon, which is soft, anechoic to hypoechoic, they are generally chorionic lymphangioma, and they have a septa also. So if you find the lesion originating from the third layer, which is hypo to anechoic with the septum, the possibility of a lymphangioma is there. And if they are in the stomach, then you should rule out ectopic pancreas versus hematomas. Pancreatic rest, generally commonly find in the stomach, but they can be found in the duodenum. This is one of the case where the pancreatic rest was in the duodenum, but commonly they are present in the pyloric antrum or the mid-body. There are two types, pancreatic rest, shallow type and the deep type. Shallow type, they are generally small. They are present in the pyloric antrum and they don't require much of the follow-up, but yes, they can present as a bleed. The deep type, they are larger, usually seen in the body of the stomach. You might see the duct. So the pancreatic rest are basically type 1, type 2, and type 3. I'm not going into the detailed theoretical discussion, but generally they have a ductular anechoic structure along with the hypoechoic originating from the third layer with the irregular fourth and thickened fourth layer. The possibility of the pancreatic rest is very high, and these patients also don't require a long-term follow-up. Another common lesion which originate from the fourth layer, schwannoma, again they have a very low malignant potential. They look like cyst. Calcification is rarely seen, but when you take the biopsies, they are S100 positive, c-KIT is negative, and they originate from the orbital plexus. So why it is important, the fourth layer, either it is schwannoma and leiomyoma or the GIST. Schwannoma and the leiomyoma, they don't require any follow-up, while GIST, they require follow-up and they have a malignant potential. It is important when you come across with the fourth layer lesion, you have to take the biopsy to prove that are you dealing with the GIST, or are you dealing with the schwannoma, or are you dealing with the leiomyoma. And on that basis, you can plan. And if the lesion is more than 5 centimeter, the possibility of a malignant GIST is there. These patients may require neoadjuvant therapy. It is important to take the biopsies. And I think Dr. Surinder Rana is going to cover in his talk. Another important tumor is the glomus tumor, which is vascular, originating from the fourth layer. They are hyso to hypoechoic, and on biopsy, they are SMA and vimentin positive, and they have a positive Doppler signals. So by that, you can predict, are you dealing with the glomus tumor or other subepithelial lesion. When we talk about the GIST, which is very important, I think this always require consideration, and GIST are mostly found subepithelial lesion of the gut GI tract, which require treatment. The immunohistochemistry, they are CD34 and CD117 and DOG1 positive. They mostly arise from the fourth layer. Size of the primary correlate with the risk of metastasis. If they are more than 5 centimeter, risk of metastasis is very high. By putting the elastography and as well as by doing the contrast US, you can also predict about the nature of the GIST, and these patients require definitive treatment. So they are CD34 and the c-KIT positive. They originate from the fourth layer. Generally, the calcification is not the feature of GIST. They are more common in the leiomyomas, but you may find the calcification. Sometimes you may find the cystic spaces. So when you talk about the diagnosis, US diagnosis for the GIST, US has a fairly high accuracy ranging from 80 to 100% diagnosis of the GIST, either by EUS or by using the EUS and FNA. And it also helps in differentiating the malignant versus benign GIST. So just to summarize, the fourth layer lesion, which is important, GIST, leiomyoma, and schwannomas. GIST are positive for the c-KIT and CD34, while they are negative for the actin as NS100, and they have a malignant potential. These patients require close follow-up. So if the GIST is less than 2 centimeter, you can do the 6-monthly follow-up, or if it is less than 1 centimeter, you can do the 6-month follow-up. If GIST is larger in size, they require removal because they have a malignant potential. Leiomyoma is negative for the c-KIT and the CD34, but they are positive for the actin, while schwannoma is positive for the S100. So if you have a fourth layer lesion where you are not certain, getting the tissue diagnosis and doing the immunohistochemistry help in finding out the nature of the fourth layer lesion, and that can say that does we follow up this patient or should we go for the definitive treatment. Doppler signals are positive in patients of GIST, while they are very less and negative in cases of the leiomyoma or in cases of schwannoma. Similarly, elastography give the pattern. On qualitative elastography, if you find a homogeneous stain pattern, that favors about benign, but in the malignant lesion, generally it is heterogeneous. More blue is indicated towards the stiff, and sometimes you can do the elastography guided biopsies also. So elastography sometimes also help in predicting, are you dealing with the benign or are you dealing with the malignant subepithelial lesion. Look at here, this is a subepithelial lesion originating from the fourth layer. On elastography is complete blue. That favors that possibility of a malignancy is very high. When we talk about the contrast EUS, generally the contrast enhanced EUS is not practiced in our country, but yes, contrast EUS can help in differentiate between the malignant GIST versus benign. You look at the microvascular pattern, the sensitivity of picking the benign versus malignancy is around 78 to 100% with the specificity of 80%. And what you see in contrast EUS, you see the irregular subepithelial tumoral vessels, which shares about you are dealing with a malignant GIST, as well as it can also predict about the response to the anti-cancer immunitive drug. If the tumor is vascular, the possibility of response to the immunitive is very high. If you find a non-enhancing spot, that also favors about the malignant potential. So this is the study what they found. If the lesion is more than 3 centimeter with a non-enhancing spots or irregular vessel, it has a very high specificity of picking up the malignancy, that just is having a malignant behavior. Now for the better visualization, I have already covered few more things which I want to cover, that you should not compress the tumor with the balloon or by your scope. Give injection buscopan in still water. Avoid putting your water into the esophagus. If you don't have a mini probe, just with the water channel of the scope, you instill the water and you will get the good coupling between the submucosal and subepithelial lesion versus your transducer, and you will get image the edge of the lesion to find out about the layer of the origin, and the echo pattern is important to give the idea about the nature of the lesion. When we talk about the tissue acquisition, I think Dr. Rana is going to talk, but a just line, a
Can we summarize? I think
forward wing scope help in getting the better forward wing scope with the cap. You can help in getting the better biopsy of the subepithelial lesion. So to summarize, ladies and gentlemen, EUS help in differentiating the extramural versus intramural lesion. In intramural, you confirm the layer of origin. If it is originating from the deep mucosa, if it is hypoechoic, that is third layer, hypoechoic on the basis of site, either it is a granular cell tumor, carcinoid, leiomyoma, deep biopsy can be done if it is not vascular, or you can follow up of these patients, or you can take the EUS guided FNA. If the lesion originating from the submucosa, that is the third layer. If it is hyperechoic, the possibility of lipoma is there. If it is hypoechoic, possibility of pancreatic rest, inflammatory fibroid polyp or fibroma, and anechoic generally are the cyst, which is duplication in cyst. If there is a atypical EUS feature, either from the third layer, you can do the unroofing and you can do the biopsies, or you can do the EMR and ESD. But if the lesion originating from the fourth layer, which is less than 1 centimeter, you can follow up. But if it is 1 to 3 centimeter, do the EUS FNB rather than FNA. Do the immunohistochemical marker and you can plan, does this patient require surgical intervention or not? If the patient has an ulcerated lesion, you don't require EUS guided biopsy. You can take the biopsy from the edge of the lesion. Thank you for the patient's hearing.
Thank you, Dr. Puri. It was a very nice exposition about the role of diagnostic EUS, and also given us some common features that you find on biopsies, also the c-KIT mutations and whatnot. So now I think we'll please stay back. I think we'll have some questions at the end. Right now, I don't see any questions. Right,
I have de-shared my screen so Dr. Rana can share his slides.
Yeah. So we can move to the next talk. It will be by Dr. Surinder Rana, Professor of Gastroenterology from PGI Chandigarh. He is a renowned expert in endoscopic ultrasound. I think we'll have to hear from him as to the role of FNA, tissue acquisition in the subepithelial lesions. Over to Dr. Surinder Rana, please.
Good afternoon, everyone. I am Dr. Surinder Rana, Professor of Gastroenterology at PGI Chandigarh. And at the outset, I would like to thank Dr. Manoj and Dr. Avinash and the members of the organizing committee for inviting me and giving me an opportunity to participate in this great academic conference. We have just heard a beautiful lecture on role of endoscopic ultrasound in evaluation of submucosal lesions, and in continuity of the same, I am going to talk about role of EUS, FNA and FNB in evaluation of patients with submucosal lesions. We all know that when we have submucosal lesions, we have three aims to achieve. First is to have an accurate diagnosis. Second is to predict the behavior of the submucosal lesion, whether it is a benign lesion or whether it's a malignant lesion or whether it's a potentially malignant lesion. And in case we have a lesion which looks like to be malignant, we have to plan a medical treatment, especially imatinib for patients with stromal tumors. In that case, we need to look at the receptor profile of the lesion. Now, when we have endoscopy, EUS, and cross-sectional imaging like CT and MRI, why do we need a biopsy in submucosal lesion? I think like for all other diseases, in submucosal lesions also, the tissue is an issue, because the differential diagnosis of submucosal lesions, as we have just heard, encompasses both non-neoplastic as well as neoplastic lesions. And when we do an endoscopy, we all know that the endoscopic evaluation of that lesion is not diagnostic. And majority of these lesions are out of the reach for a conventional endoscopy biopsy forceps. The only situations where endoscopy may be diagnostic is if there is an ulcer and you target that ulcerated area of the lesion and you may get a diagnosis. Or if you have a low risk lesion which has a characteristic endoscopic appearances like a pancreatic rest located at the greater curvature of antrum, or you have a lesion which is quite obviously looking like a malignant lesion and surgery is planned, for example, a large and ulcerated mass like a high-grade gastric cyst. All other lesions, endoscopy and biopsy is not diagnostic. What about using a jumbo biopsy forceps? The studies have shown that with use of jumbo biopsy forceps, the diagnostic yield increases to about 50 to 80%, but it is still far away from satisfactory. Now we have EUS with us, but we know that in many circumstances, the differential diagnosis of submucosal lesion is not straightforward with EUS evaluation alone. EUS will tell us that it is from which layer of the GI wall the lesion is arising. But then they just look at example of an hypoechoic submucosal lesion arising from the fourth layer. The differential diagnosis encompasses from a potentially malignant lesion like a GIST to a benign lesion like leiomyoma, schwannoma, and then you can have other mesenchymal tumors which can have a varying malignant potential. So just by looking at the layer from where the lesion is originating, we may not be able to get a differential diagnosis. And as an endoscopist, it is very important for us to accurately predict the behavior of lesion. Some of the features which might help us is the location of the lesion. We know that the lesion which is located in esophagus has the least malignant potential in contrast to lesion which is located in duodenum. Then we have heard beautifully about the various EUS features and contrast EUS features that can help us in differentiating between benign and malignant lesions. But the problem is if these lesions, if these features are not present on EUS, it still does not rule out a malignant or a potentially aggressive disease. Now, just recapitulate how do we approach a submucosal lesion. Once we identify a submucosal lesion on endoscopy, naturally we'll do an estimation of size, its appearances, but again, it has got a very poor sensitivity and specificity for accurate differential diagnosis. Many of these lesions undergo an endoscopic biopsy, but as I've just told you that endoscopic biopsy, the yield is very low. Thereafter, we look at the size of the lesion. If the lesion is less than 1 centimeter, we just do an yearly follow-up, and if the lesion is growing, then only we do an EUS. On the other hand, if the lesion is more than 1 centimeter, an EUS is to be done, and first step is to find out whether it is an extramural or an intramural lesion. And if in an extramural lesion, then you work up the patient as clinically indicated for an extramural lesion. In contrast, if it's an intramural lesion, we look at the EUS characteristics. Hyperechoic lesions by and large are benign, so you follow up only in selected cases where there is a clinical suspicion of a malignant lesion, because majority of them would be either a lipoma or a fibroma. If they are anechoic lesions, you put a Doppler. If they are Doppler, it's vessels. Most of the time, these are varices. And if it's a Doppler negative anechoic lesion, these are cystic lesions. Again, the malignant potential of an intramural cystic lesions is very, very less. The problem arises when the lesions are hypoechoic or have a mixed echogenicity. In these conditions, you have to decide whether to straight away proceed with surgery or do a tissue acquisition. Before I talk about tissue acquisition, it is important to understand that all submucosal lesions do not need a tissue acquisition. Tissue acquisition is needed when you have a submucosal lesion with a presumptive diagnosis based upon imaging of an unresectable GIST, for which a tyrosine kinase inhibitor is contemplated. In that situation, you need to do a biopsy to look at the CD117 status. Patients who have a previous history of a malignancy with a submucosal tumor, and now you are suspecting it to be a metastasis, then again a tissue acquisition is required. And then finally on EUS, you think that it could be a lymphoma or a neuroendocrine tumor, then again a tissue acquisition is needed. However, tissue acquisition is not needed if the submucosal lesion is symptomatic, for example, with pain or with bleeding, and surgery is anyway needed. In that situation, tissue acquisition is not needed. If there are typical echo features, that is hyperechoic lesion of a lipoma, and then small less than 2 centimeters submucosal lesions of esophagus and stomach, by and large are benign. If you have a typical EUS features of a benign lesion, then tissue acquisition is not needed, and these lesions need to be on a serial follow-up. However, I have to admit that for duodenal and colorectal submucosal lesions, we don't have any sufficient data to suggest any recommendation. So whether to acquire tissue or not should be individualized in any patient based upon the size, EUS appearances, and the symptoms. Before we go on with the tissue acquisition, it is important to do a good EUS because the strength of EUS is its capability to guide the choice of optimal tool of tissue acquisition. For example, if there is a small lesion which is lying within the second or third EUS layer of GI wall, it can be completely resected by an endoscopic mucosal resection, whereas large lesions with EUS criteria for malignancy are best referred to surgery. So it can help you to decide the way how to acquire a tissue acquisition and which lesions can be directly referred to the surgeon. Now, what are the tools of tissue acquisition? Just to recapitulate, we have forceps, which are endoscopic biopsy forceps, where we use bite-on-bite technique, unroofing techniques, endoscopic resection techniques, and then we have EUS-guided fine needle aspiration or a fine needle biopsy, and finally we do surgery also as a means of tissue acquisition. But the important thing to understand is that for submucosal lesions, we need to have a sufficient amount of tissue so as to perform immunohistochemistry because the diagnostic features as well as the prognostic features depend upon the IHC features. So the aim of tissue acquisition is to acquire a sufficient amount of tissue to have a cytological diagnosis, perform immunohistochemistry, and do a mitotic count because the number of mitoses will tell us about the behavior of the lesion. And if you look at air-dried and alcohol-fixed slides, we can only do a cytology. And hence, if we are doing a fine needle aspiration, it is also very important to have cell blocks because on cell blocks, we can perform immunocytochemistry. And if you are doing a fine needle biopsy, have a tissue core to perform the immunohistochemistry. Role of endoscopic biopsy has already been highlighted. The mucosal biopsies are usually insufficient. So bite on bite technique where you go on digging from the site of biopsy, having 2 to 8 bites using a conventional size forceps, the diagnostic rate is very poor of about 38%. And moreover, it can lead on to fibrosis, which may negatively impact the future resection technique. Hence, bite on bite technique is usually not preferred in the current times for tissue acquisition. The jumbo biopsy forceps are bigger biopsy forceps, but again, the diagnostic yield is about 50 to 80%. What about EUS FNA? It is a very promising technique because it's a real-time tissue acquisition. How do we do it? You take one slide which is fixed by air drying, stained with modified Giemsa stain and examined on site for specimen adequacy. The other slides are fixed in alcohol and stained using PAP technique. And then you have to take a cell block material which is fixed in 10% formalin, embedded in paraffin, cut thinly, and then stained with HNE stains. And the diagnosis is established by doing a smear cytology, histology, or a cell block analysis, and immunohistochemical staining of cell blocks. Although looking very promising, there are a number of problems with the EUS FNA for submucosal lesions. The first and foremost is the diagnostic yield is still about 70 to 80%. And the problem is for smaller lesions less than 3 centimeter, the diagnostic yield is much lower. 40 to 50% for lesions measuring up to 1 centimeter and 60 to 70% for lesions measuring 1 to 3 centimeter. And we all know that these are the lesions where we require an accurate diagnosis because they don't fit into any strict criteria for surgery. And we may be able to differentiate between a benign and a malignant lesion, but EUS FNA has a very poor diagnostic yield for determining exact type of benign lesion being present. And then to increase the diagnostic yield, we need ROSE also, which increases the cost. And the diagnosis of malignant GIST by cytomorphological findings alone is very limited. And hence, EUS FNA has a very limited role in prognosticating the GIST. And then there were prospective studies which have compared EUS guided FNA versus bite on bite biopsy techniques, and they didn't find any significant difference in the diagnostic yield between the two techniques. Now, how to improve the diagnostic yield for an EUS FNA? One is to obviously use ROSE, as we know that ROSE increases the diagnostic yield for EUS FNA. And then what's the impact of needle gauge? The study evaluating 22 and 25 gauge needles found a similar diagnostic yield, but when we use a 19 gauge needle, the diagnostic yield significantly improves over 22 and 25 gauge needle. And then whenever you are sampling a patient suspected of GIST, it is important to use a negative suction pressure to get a sufficient tissue, because studies have shown that the GIST cells tend to have tight to tight cell adhesions. So with suction, you tend to have a better yield. And then obviously you have to prepare a cell block to do a immunocytochemistry. Now, since there were limitations of an EUS FNA in the diagnostic yield, came the role of EUS FNB. We know that these are novel FNB needles which have been developed to overcome the technical limitations of fine needle aspiration needles as well as the true cut biopsy needles which came in between. There have been various designs like reverse bevel needle, fork tip needle, and leading sharp tip needle. The advantages of these needles is that you have a ability to obtain specimen which is suitable for histology as you get a tissue core, and there have been very encouraging results from the EUS FNB done from the lymph nodes and pancreatic tumors. What about submucosal lesions? The studies have reported technically similar and equally safe as FNA with better tissue acquisition that is achieved with fewer needle passes and hence improved diagnostic yield by immunohistochemistry. This is a recent meta-analysis which has been published on the role of EUS FNB for submucosal lesions, which included 10 studies and 669 patients comparing FNA versus FNB. The diagnostic accuracy for submucosal lesions was significantly better with FNB sampling. FNB required fewer number of passes to establish the diagnosis. And importantly, the histological core procurement was significantly higher for FNB as compared to FNA being 89.7% versus 65%. Similar results obtained from a large multicentric study again published recently in GIE. It is a 229 patients who underwent 115 underwent FNA and 114 underwent FNB. The cell block for FNB required fewer passes to achieve the diagnosis. The number of passes were not different for Rose adequacy. Immunohistochemistry was more successfully performed in FNB samples as compared to FNA samples. So they concluded that EUS FNB is superior to EUS FNA in diagnosis of submucosal lesions. Also importantly, EUS FNB is superior to both FNA alone as well as combined FNA and Rose because of its ability to procure the tissue core for immunohistochemistry. So is it that EUS fine needle biopsy is a panacea for diagnosis of submucosal lesion? Unfortunately, the answer is no, because as we started using FNB more commonly, we realized that the diagnostic yield for EUS FNB for lesions which are less than 2 centimeter in size is again 75 to 80%, in contrast to about 95 to 98% for lesions which are bigger than 3 centimeter. So there have been few attempts to increase the diagnostic yield of EUS FNB. One way is to use a forward-viewing echoendoscope where you get an end-on view of the submucosal lesion, but again the results have not been so convincing. The core biopsy was still obtained only in 65 to 75% patients with small lesions, and the prediction of behavior of GIST despite using EUS FNB still remains a challenge, and the cost of needle is again another important factor which is important in countries like ours. So just to recapitulate, what's the role of EUS guided tissue acquisition? Again, this is a submucosal lesion. On EUS, you find it to be a complex cystic lesion. The problem with EUS is that when you have large lesions, it is very difficult to accurately find out the layer of origin of these submucosal lesions. But here it appears that it is arising from the fourth hypoechoic layer or the muscle layer. But since it has got an atypical features, its size is about 4 centimeter. We did an EUS FNB and it turns out to be a cystic GIST. And this patient underwent surgery with a Ki67 index of 12%. So it's a potentially malignant GIST. Again, a submucosal lesion in duodenum. On endoscopy and biopsy, you're not able to get any diagnosis. You do an EUS, you again find a submucosal lesion which is of a variable echogenicity, hypoechoic and hyperechoic. So whenever you have a mixed echogenic lesion, you have to get a tissue to find a diagnosis. On a Doppler, it is hypervascular. And when we did a EUS guided FNB in this lesion using a 25 gauge needle, this was a metastatic renal cell carcinoma. This patient had undergone a nephrectomy 10 years ago. On the other hand, when you have such sort of appearance, well-defined hypoechoic lesion arising from the second muscle layer, that is muscularis mucosae, most of the time these are lipoma, and this was confirmed in the EUS guided tissue acquisition using a 22 gauge FNB needle. Now again, here you see it's a gastric submucosal lesion of a variable echogenicity arising from the fourth layer, clearly documented on the zoomed image. Here we do a contrast EUS, and when you do a contrast EUS, you find there is a homogeneous uptake of contrast. So this suggests a possibility of a GIST with a low malignant potential. We did a EUS guided FNB with a 22 gauge acquire needle. The cytology was suggestive of a spindle cell tumor. On IHC, it was CD117 positive, suggestive of GIST. The mitosis were 2 per 20 high power fields. You don't have so much sample that you can calculate 50 high power fields. The Ki67 index was 2%, again suggesting a low malignant potential. This patient undergoes a wedge resection laparoscopically, and the final histology, the dimension is 3 centimeter, fairly corresponding to the EUS calculation of the size. The histology is GIST, which is spindle cell type. Mitotic count was less than 5 per 50 high power field. There was no necrosis, no lymphadenopathy. CD117 was positive. DOG1 was again positive, a marker for GIST. SMA, a marker for leiomyoma, was negative. Ki67 was 2 to 4%, and risk assessment was low risk. So fairly corresponding to what we got with a US FNB. Another example, now here you see it's a submucosal lesion arising from the fourth layer. Now it has got a variable echogenicity, necrotic areas. Although it is well defined, these features suggest a possibility of malignant GIST. This patient undergoes a contrast enhanced endoscopic ultrasound, and then you see large tumor vessels. When you see these large tumor vessels on contrast, it again suggests a possibility of malignant GIST. This again patient undergoes an EUS guided FNB. It's a high Ki67 index, and finally the patient undergoes a surgery. It corresponds with a diagnosis of a potentially malignant GIST. But then how to best acquire a tissue from small submucosal lesions? This is a new technique which is coming up, a recently paper published in Digestive Endoscopy of a mucosal incision assisted biopsy, where you partially remove the mucosa and expose the lesion and take a biopsy. And this has shown very encouraging results in smaller submucosal lesions. And this is again a recently published paper where it's looked at the diagnostic yield of 3 techniques, FNA, FNB, and mucosal incision associated biopsy. For smaller lesions, the mucosal incision associated biopsy is best. As the size increases, the gap between FNA, FNB, and MIAB decreases. So for a larger lesions, maybe you can get a diagnostic yield better with FNB, but for smaller lesions, MIAB is better. So to finally conclude, we have learned that some mucosal lesions which are indeterminate after endoscopy in EUS, they are a diagnostic dilemma. Small hypoechoic lesions of second and third layer, endoscopic resection may be considered because it will be curative as well as diagnostic. The larger lesions, we know that EUS FNB has a good diagnostic yield. However, smaller hypoechoic lesions of fourth layer, which are measuring between 2 to 4 centimeter, are a challenge currently. If you have features of benign lesion both on EUS as well as contrast EUS, a follow-up may be indicated. However, if there are worrisome features, then tissue acquisition, either using a mucosal incision associated biopsy for lesion less than 2 centimeter and 2 to 4 centimeter EUS guided fine needle biopsy. We still do not know how best to manage GIST which are less than 3 centimeter in size. So once we understand the natural history of these lesions much better, we may be better able to give an idea of how to manage them. And then EUS guided through the needle biopsy forceps and confocal laser microscopy are promising results, promising techniques. The initial results are very encouraging, and we need more data from prospective and comparative studies. Thank you so much for your patient hearing.
Thank you, Dr. Surendra Rana. It was a wonderful lecture on the utility of this EUS guided FNB in tissue acquisition, particularly the subepithelial lesions. I'll also invite the co-chairpersons and the panelists for a panel discussion, which will be for the next 10 minutes. Dr. Chalapati Rao and Dr. Satish Rao are here. I think Dr. Shiran Shetty is unable to join us because of some personal issues, and I invite the chairpersons also to join. We'll quickly go through if there's any questions in the chat box. Right now, we don't see any questions. So to begin, to Dr. Chalapati and Dr. Satish, and I will request Dr. Rana and Dr. Puri to pitch in with their comments also. So now we have heard both Dr. Rajesh Puri and Dr. Surendra Rana discuss about the utility of EUS and subepithelial lesions. Dr. Chalapati, how commonly do you see in practice, like where you need or where you are referred for US evaluation of the subepithelial lesions compared to all your, references for endoscopic ultrasound in a day-to-day practice? How often do you get to see these things?
Yeah, it is common to have a referral because most of the times it is because of the patient's anxiety that they get, when there is a swelling, it is reported on endoscopy. So that is one reason, but commonly we get like weekly some 3 or 4 cases from outside referrals we get. So in my practice pertainingly to that, 1 or 2 cases in every 200 to 250 procedures we get some lesions, commonly in the esophagus or in the distal antrum, like that usually.
Right. So given that we just heard Dr. Puri also discuss about the utility of EUS as compared to a cross-sectional imaging like CT or MR, the data that was initially shown, that was all were like imaging or the of CT of generations in the early 2000s or in the late 90s. With the current generation, CT and MR, majority of the times they're able to tell them that, even they're able to tell us that this is just more likely with all the complexities, which layer they're coming out from and all that. We know that CT is good for distant metastasis, but with the current generation CT, do you think it's also building up, or they're able to tell us more about the layers from which it is coming from? Dr. Satish, what do you feel?
Most of the times nowadays patients are coming with CTs only. After when the endoscopies are done, almost most of this outside physicians or surgeons usually will do the CT. Then after that they will refer for a US most of the times. And I feel CTs may not able to pick up all the features, especially if the lesions are very less than 2 centimeters. And in these cases, US is required.
Okay. Dr. Puri, would you like to add anything more? Like the data that you showed, Dr. Puri, you're muted. Please unmute yourself.
Not be described on the CT scan or MRI.
Sorry?
Yes, I think the layer of origin on the basis CT cannot give the idea about the layer of origin. Yes, if the lesion is larger, more than 3 centimeters size, it can predict the nature of the lesion, because the common tumor which we encountered is either a cystic lesion or a leiomyoma or the GIST. Pancreatic rest generally don't be picked up on a CT scan or so. So the common subepithelial lesion is GIST, which require a treatment. Yes, CT can fairly give the idea. But if you look at the GIST also, you require a tissue diagnosis or a direct surgical intervention.
Right.
So if you require a tissue diagnosis, you have to go for an EUS examination. And EUS definitely had an upper edge. You do a CT, you see there's a subepithelial lesion, probably GIST, no metastasis. And subjecting this patient for the wedge resection of the gastric body, generally the surgeons are also interested to confirm, and as I said, fourth layer lesion could be a leiomyoma or could be a glomus tumor or could be a schwannoma. Schwannoma has a very low malignant potential. So I think adding, because if you talk about the literature, fourth layer lesion, how is EUS impact on the basis of CT scan, we don't have data up to my best of knowledge.
Right. But how good is
when we
EUS
talk about
also?
the clinical practice, when we talk
Yes.
about the clinical practice, majority of these patients go for the EUS examination and require a biopsy, because you can plan the treatment. And that's my take on this. Rana,
And another question to you about how good is EUS in looking at the layers? Like, there are sometimes we tend to overestimate or underestimate the layer from which it comes from, isn't it? Or what is the trick that you would like to tell, like, to the people who hear?
Question to me?
Yes.
So yeah, this is very important. As I said, to know about the layer of lesion, you have listened the talk from Dr. Surendra Rana, large lesion which is exophytic, difficult to differentiate from which layer it is originating. But the best trick is you do the transition zone from the normal layer to the subepithelial lesion, from where you put a water, examine from there. That is number one. Try to compress, because what we have learned in EUS, we try to remain very close to the subepithelial lesion and we compress the gut wall. And number third, we compress with the inflated balloon also. So you should be in the center of the lesion, or you should be in the At the corner, at the transition zone, better is a transition zone, but center is also give the fairly very good idea if the lesion is not very big in size. If the lesion is 5 centimeter, keeping perpendicular center is also not going to give. The transition zone is the best. If the lesion is 2 centimeter or so, keeping your scope perpendicular in the center also give the layer of horizon. Put water, give scope and distend the stomach. That help in knowing about the nature of the lesion. If you are not very sure, I think mini probe is very good to give the layer of origin, and especially in the small lesions. The problem arises only in the duodenum in my practice, where it is sometimes difficult, but you fairly see the fourth layer and you can comment that is the lesion originate from the second and third, which is a difficulty, but fourth layer origin from the duodenum is also very easy.
Right. Now, moving on to the tissue diagnosis part, Dr. Rana has beautifully given us the role, but where the US helps. But for the, just I'm putting being a devil's advocate, is US FNB getting obsolete, or the indications are going down as we hear from what Sir had to speak? Because with the advent of third space endoscopy, EMR, ESDs, majority of the third layer lesions are being taken out with ESDs and STIR and whatnot, and EFTR, which has come up now for even for muscle layer lesions. So Dr. Chalapathy and Dr. Satish, what is your view? How are things going to be in the next 5 years from now? Where do you think US FNB has a role for tissue acquisition in such subepithelial lesions?
As you told, it is some of the recent literature show that it's still controversial whether to take a biopsy in some lesions or not. But still, I feel that in the small lesions, maybe around it would maybe a 1 to 2 centimeter lesions, US FNB will have some edge over the before any definitive procedures, I feel.
Dr. Chalapathy, what is your take on this?
Yeah, I feel like coming to the future, I think still FNB has a role, especially in GIST-like tumors where neoadjuvant therapy is needed, unresectable tumors. But probably see, we have moved from taking a biopsy, colonoscopic biopsies for polyps. So we straight away resect them. That is mucosal. So similarly, since we have advancements in resections of the submucosal lesions, probably there is a good advantage if we do a procedure like STER or EFTR. That might take the lesions in toto. So that is also curative. This is going in line with the surgical principles. So that can give you the margins, that can give you a lot more tissue, that can clear the tumor like that. So for lesions around 2 centimeters, around that, I think STER and EFTR has a good role. And for symptomatic lesions, and probably the role of FNB might come down.
Okay, sure. Thank you. I think Dr. Rana, your final comments, and then we conclude this.
I have one question.
I think we are just running short of time. We got our things. So, Dr. Rana, your final comments on the role of FNB, and then we'll wind up, please.
Yeah, I think the point you raised is quite valid, but you have to understand that STIR and ESD are therapeutic procedures. They are meant to relieve the patient of the symptoms. So obviously in a symptomatic patient, you have to decide between surgery and STIR or ESD. The question arises in an asymptomatic submucosal lesion where you have to get a diagnosis as well as prognosticate the lesion. As I've already talked about, lesions which are less than 2 or 3 centimeters, we still don't know their natural history, whether we need to treat them or not. So question of STIR and ESD will not arise for diagnosis. It will arise probably for the treatment of this lesion. And tissue acquisition, again, one has to take everything in totality, the clinical picture, the endoscopic appearance, and the treatment plan. And then you decide whether you want to do a tissue acquisition or not. And if tissue acquisition is to be done, then it is dependent upon size, as I've already told you. Any lesion which is more than 3 centimeters, FNB has got a very good diagnostic aid.
Thank you so much. Thank to both Dr. Rajesh Puri, Dr. Rana, and to all my co-panelists and chairpersons for this wonderful lecture and panel discussion. I think we'll move over to the next session. Thank you so much.
Thank you. Thank you, sir.